Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today I'm going to present this special lecture because of the relevance with Ramadan. Millions of people, they have diabetes, and many of them, they would like to fast. And this lecture would help you understand how these medicines are better used and how we can optimize them during the month of Ramadan so that these individuals, these patients with diabetes, they can fast safely. So the topic is optimization of anti-diabetic medication during Ramadan. Now I'm going to present 20 different recommendations which are agreed upon by Pakistan Society of Internal Medicine, and they are also actually agreed upon by Pakistan Academy of Family Physicians. So I'm going to present them one by one. Recommendation number one is that all patients should see their doctors 2 to 4 weeks before Ramadan to have their medication adjusted. So this is, I think, highly desirable because patient would not be able to judge if he or she is in that group where there is a high risk of hypoglycemia. So it is best that if they see their doctor, the doctor may say that the same medication will be continued, or the doctor may suggest some medication. So this is recommendation number one. The recommendation number two is about those people who are taking metformin as monotherapy. Metformin may be taken twice a day, 500 milligram, 750 milligram, 850 milligram, or 1 gram twice a day. So no change is necessary because metformin has got very low potential of causing hypoglycemia. Those patients who are taking metformin XR formulation, the slow release, long acting formulation, once a day, I think it is best if they take once a day medication at iftar. So that will be safer. Then if somebody is taking metformin 3 times a day, 500 milligram or 750 milligram or 850 milligram 3 times a day, in that case, I think first step is that the morning dose can be given at Sahri, and the afternoon and night dose can be combined and given at iftari. Now this is an example. Somebody was on metformin 500 milligram 3 times a day with each meal, that you can change it to 500 milligram at Sahri and 1000 milligram, which is actually afternoon and night dose combined at iftari. So this will be very convenient, and patient will not have any problem and he will be able to fast safely. So this was a recommendation number two for those who are on metformin monotherapy. Now, recommendation three is about those people who are taking DPP4 inhibitors as monotherapy. And we have Sitagliptin, which is available with the name of Januvia and Trivia, which are many others. And it is 100 milligram once a day or 50 milligram twice a day. And the other one which is common and available in our country is Vildagliptin, and the brand name is Galvus, and Galvus is typically prescribed as 50 milligram twice a day. And then we very recently had Linagliptin with the name of Linvesta, and the dosage is 5 milligram once a day. So if any person is taking any of these drugs as monotherapy, the recommendation is that there is no changes necessary, because as monotherapy, DPP4 inhibitors have low potential of causing hypoglycemia. Now, metformin and DPP4 combination. This is very popular combination. In fact, this is my favorite also, because metformin has effect on fasting sugar, and DPP4 inhibitors have main effect on the postprandial sugar, and both drugs have common features of weight neutrality and also not the potential of causing hypoglycemia. The pharmacokinetics matches with each other very well. So very commonly these drugs are prescribed as combo pills and typically twice a day. For example, sitagliptin metformin combo is called Genumet or Triviamet. There are many other names, and the typical dosage is 50 by 1000 milligram given twice a day. Similarly, vildagliptin and metformin is also given twice a day. We have galvismet or Vilgat, and typical dosage is 50 by 500, 50 by 850, or 50 by 1000. That is also given twice a day. Now, we have already discussed that no change is necessary in metformin, and we have already discussed that no change is necessary in DPP4 inhibitors. So it is only logical that if somebody is taking these drugs, no change will be necessary. So patient can continue to take these drugs as monotherapy. But if somebody is taking sitagliptin metformin XR formulation, and that is given once a day, and I normally prescribe this once a day medication with dinner, but if somebody is taking it in the morning, I think it is recommended that that person should take it with iftar during the month of Ramadan. So this is the recommendation for those people who are on metformin and DPP4 combination. Let's move to the next recommendation now. This is about SGLT2 inhibitors with or without sitagliptin. Now, SGLT2 inhibitors, they work through kidneys, they promote glucose excretion. So whenever glucose is excreted, there is some diuresis also. But surprisingly, every person does not have diuresis. There are people, because it has got multiple actions actually. SGLT2 inhibitors have multiple mechanism of action, and we have noticed that every person does not have significant diuresis. But recommendation is actually based on the fact whether or not somebody has diuresis with these drugs or not. The common names are dapagliflozin, we have DAPA, we have Ziga. I'm sure there are many other names also. Typical dosage is 5 milligram or 10 milligram once a day. Then we have empagliflozin, which is Diampa or Jardi, and there are many other names. The dosage is 10 milligram or 25 milligram once a day. Then we have ertigliflozin, which is now recently made available, and we also have ertigliflozin combined with sitagliptin, which is available with the name of Trivia R2. So recommendation about these medicine is that they may be continued, but switch to Aftari, particularly if significant diuresis. It is, I think, it would depend on person's, uh, if that person complains of diuresis, then I recommend that the medication should be taken at Aftari, because uh, long hours of water deprivation in summer month when there is going to be sweating also. So it would be best if these drugs are taken at Aftari, so that patient can drink water before next Sahri, and I think that is the recommendation. But if somebody does not have significant diuresis with these medication, that person can continue to take the medication the way that person was taking before, in the morning or at night or whatever time. Sometimes it is given twice a day also. So whatever time that patient is taking, that person may continue. Now, this recommendation is about SGLT2 inhibitors and metformin combination. As I said, DPP4 inhibitors and metformin combination is very popular. SGLT2 inhibitors and metformin combination has also become very popular because both pair very well, both lowers glucose in a very decent way and without causing hypoglycemia, without promoting any weight gain. They have different mechanism of action, and so the metformin the main action is in the fasting sugar. SGLT2 inhibitors would have action most importantly in the postprandial, but also in the fasting state. So what is the recommendation? These are actually some of the combinations available. Dapagliflozin with metformin is available with the name of Dapamet and Zigamet, and empagliflozin with metformin. The famous names are Diampa M and Jardimet, and I think these medicine can be continued as such if there is no significant diuresis. And if somebody does have some diuresis, you could continue the same dosage at night, but in the morning dose, you could take out this SGLT2 inhibitors. Maybe you can ask the patient to take metformin alone with sahri, and because during the day, patient would not then develop dehydration. So this is, I think, based on common sense, especially the fast is going to be long, and there's season, a summer season. So I think uh, that is it is possible, it is recommended that patients should take it at iftari. Thiazolidinedione drugs, they were very popular. They still are very, very useful. As a monotherapy, they're not very commonly prescribed, but some people are taking as monotherapy or with other drugs. And the examples in our country are Pioglitazone, Pioglitazone, and Zolid. Recommendation is that they have no problem and they do not cause hypoglycemia. So whatever dose patient is taking, 15 milligram or 30 milligram or 45 milligram, which is the maximum recommended dose, whatever dose patient is taking in the morning or at night, patient may continue during Ramadan also. So this is recommendation number 7. Recommendation number 8 is for those who are taking pioglitazone with metformin. You must have noticed that we have many combination with metformin. So metformin with pioglitazone is another combination which is prescribed, Pioglitazone plus and Zolid plus. These are two drugs which are used. Uh, I think recommendation, since we have already said metformin does not require any modification, pioglitazone does not require any modification. So combination will also be continued as such during Ramadan. So the morning dose will be taken with sahri, and afternoon dose and the night dose will be taken with iftari. So otherwise no changes and no reduction in dosage is required. So this was recommendation number 8. Recommendation number 9 is about those who are taking alpha glucosidase inhibitor. Now these drugs, they actually prevent glucose absorption, or at least slows down glucose absorption after the meal from the gut. And these drugs are known not to cause hypoglycemia in any situation. And the only example we have is a glucobay. Patient may be taking 50 milligram twice a day or 3 times a day. Ideally, these medicines are to be taken with every main meal. So if we normally take 3 meals, so if the patient is taking 50 milligram with 3 meals, the recommendation is that if somebody is taking twice a day, no change will be necessary. Patient will take morning dose with sahri and the night dose with iftari. And this drug has to be taken with meal. And afternoon dose will be dropped since there will be no meal in the afternoon, so that will be dropped. Sulphonylureas, I think this is where some changes would be needed. This is the recommendation number 10. First recommendation is that glibenclamide, very famous drug, very popular drug called Danil. It is very famous and popular because it is one of the oldest sulphonylureas, and number 2, it is very, very potent and it is very cheap. So many people in our country, they take it as monotherapy or in combination with metformin. When it is combined with metformin, it is called glucovance. So it is recommended that these drugs, glibenclamide as a monotherapy or glibenclamide combined with glucovance, should be avoided during Ramadan because it has got high potential of causing hypoglycemia. Then a newer generation sulfonylureas, glimepiride, Emeril or Getril are the famous names, or gliclazide, diamacron MR is another popular name. So in combination with metformin like Emeril MSR 1 or 2 and Getformin 1 or 2 can be taken once daily at iftari. So since they have less chances of causing hypoglycemia as compared to older generation, they can be taken, but it is recommended that since they are sulfonylureas, they should be taken as once a day medication at iftari, not with sahri. So this is the recommendation number 10. If patient is taking any sulfonylurea twice a day, then morning dose should be reduced to half or skipped completely to avoid any hypoglycemia during the day. Now this is recommendation number 11. This is about GLP-1 receptor agonists. So these drugs are available with the name of liraglutide injection form once a day. The trade name is Victoza. And then we have dulaglutide, which is once a week. The trade name is Trulicity. And now we also have semaglutide, that once a week. The trade name is Ozempic. Now these medicine actually once a week and in a fixed dose, you can't really make any adjustment, and in fact, and no adjustment is needed as these drugs do not cause hypoglycemia. There, or at least they have very low potential of causing hypoglycemia because their stimulatory action on beta cell and also the inhibitory action on glucagon, the alpha cell, is glucose dependent. So that is why these drugs can be continued. In fact, GLP-1 receptor agonists will perhaps be the best during Ramadan because they control your appetite. So perhaps fasting will be easier for those who are taking GLP-1 receptor agonists. We of course cannot prescribe these drugs for this reason only, but if somebody is already on these medication without any changes, patient can continue to fast. Basal insulins. Now, basal insulins are those which have flat profile without a peak. The famous names are glargine, the trade names are Lantus, Toujeo. Toujeo is actually the same, only a concentrated form of Lantus, and Basagine, which is our local brand of glargine. And then we have Detamir, which is Levemir, and these are basal insulin. And so recommendation is that in pre-Ramadan evaluation, we should check patients' fasting sugar. If somebody's fasting sugar is usually 120 or above, then same dose may be continued. Of course, if it is very high, then you would need to adjust it. But if somebody's fasting sugar is above 120, there is no much risk of hypoglycemia if patient continue to take the same dosage of basal insulin during the month of Ramadan. But if somebody's fasting sugar is less than 120, it is recommended that you should reduce basal insulin by 20%. Now, how do we do that? This is a very simple way. Every calculator have this function. If somebody is taking 30 units, so you subtract 20%, 30 minus 20, then percent mark, then equal to 24. So if somebody was taking 30 units, whatever time in the morning or at night, typically basal insulins are given at night. So that dosage has to be reduced from 30 to 24 to avoid daytime hypoglycemia. So this is the adjustment. Recommendation number 13 is about patients who are taking basal insulin and GLP-1 receptor agonists. This combination has also become popular amongst the injectable therapy. Now, insulin will take care of fasting sugar, basal insulin, and GLP-1 receptor agonists will take care of postprandial glucose, and both can be combined and both are injectable. They can be taken as one single injection. Examples are insulin degludec and liraglutide. The trade name is Zoltofy. And then we have insulin glargine with lixisenatide. The trade name is Soliqua. So these drugs, the recommendation is exactly the same as for basal insulin because we have already discussed the GLP-1 receptor agonists. They do not require any changes in the dosage at all. So whatever changes are needed, it is for the basal insulin. And for basal insulin, only in the last slide we discussed if fasting sugar is 120 milligram or more, same dose to be continued. If fasting sugar is 120 or less, then we have to reduce it by 20%. Further adjustments can be made on following days. Then NPH and NPH based pre-mix insulin. NPH is the insulin which is like intermediate duration action, and it has got a peak. 7 to 8 hours after injection, it would have a peak. So if this insulin is injected in the morning, it is possible that it would cause hypoglycemia in the afternoon. And in the pre-mixed insulin, these are the example. Again, there is a risk of hypoglycemia when there is a peak effect. These are the names: Humulin N, Insulatard, Insuget N, Humulin 7030, Mixtard 30, Insuget 7030. These are the common insulins which are based on NPH. They are either these three are NPH alone, these three are NPH with human insulin. So it is recommended that NPH mono and all NPH containing combos should not be taken at Sahri. They may be taken at Aftari but not at Sahri, because if you take it at Aftari, then the peak effect will be before next Sahri, and that is the time when patient is allowed to eat, so there is no risk of hypoglycemia. Now, fast-acting analog-based pre-mixed insulin. Humalog mix 25 or 50, Novomix 30 or 50, and usual morning dose can be taken at Aftari, and half of the evening dose may be injected at Sahri. Now, I will give you an example to clarify what I actually mean to say. Suppose there was somebody who was on Humalog mix 25 or Novomix 30, and he or she was taking 30 units morning and 20 units night. So this is an example. The recommendation is that this morning dose, 30 units, can be taken at Aftari, and half of this evening dose, which would be 10 units, can be taken at Sahri. So this is what is, but that is what we do. 10 units at Sahri and 30 units at Aftari. Since these insulins are injected immediately before meal, so they are definitely more suitable as compared to human insulin and combinations for Ramadan, because they are to be injected half an hour before meal. So these analogs are definitely safer and better and more flexible during Ramadan. Then short-acting human insulin, and we have Humulin R. Since it is short-acting, it is typically given 3 times a day with 30 minutes before each meal. Actrapid and Insuget R. R are given 30 minutes before each meal. And if we take 3 meals a day, then it would be 3 times a day. Now, recommendation is that afternoon dose would be, of course, dropped because afternoon meal is dropped, and morning dose reduced by 20%. Why? Because these short-acting insulin, they have some problem. Uh, their action is like 5 hours, 6 hours, and if you've taken a small sahri, there is the risk of hypoglycemia after 3 or 4 hours. So I think it is best that we reduce morning dose by 20%. And the evening dose, pre-Ramadan dose, may be continued at Iftari. If somebody was taking like uh, 12 units 3 times a day, morning 12 units will be reduced to, I think, maybe 8, and the night 12 units will be continued as such, and afternoon 12 units will be dropped. This was recommendation number 16. The recommendation number 17 is about those people who are taking fast-acting insulin analogs. Now, fast-acting insulin analogs are technically better than short-acting insulin, short-acting human insulins, because once injected, they do not make hexamers, and the action starts immediately, so they can be very conveniently taken immediately before meal. So I think they are definitely safer for fasting. Humolog TDS, Novorapid TDS, and Epidra TDS. These are all uh, fast acting. This is insulin Lispro, this is insulin Aspart, this is insulin Glulicine. These are all fast acting insulins, and their action start fast and their duration of action is also short. So the chances of hypoglycemia are much less. Afternoon dose, of course, will be dropped because there will be no meal at that time, and morning and evening dose pre-Ramadan can be continued the same dosage at Sahri and Iftari. That there is a different recommendation for short acting, because short acting human insulin should be reduced. Morning dose should be reduced by 20%, but fast acting insulin, fast acting insulin analogues can be continued the same dosage. Now, if somebody is taking the other type, human combination, I think insulin analogues, since they are technically superior to human analogues, consider switching if affordability is not an issue. Insulin analogues are technically better but significantly more expensive than human insulin. So if patient can comfortably afford, I'm sure many patients would be willing to spend some extra money to experience a safe fasting. So I think you should make this offer. Same dosage which patient was taking can be changed with insulin analog based combos or monos. This was recommendation number 17. Now, recommendation 18 is about how frequently and when we should monitor glucose. Uh, uh, Particularly patient on sulphonylureas or insulin, because these are the classes of drug which have a relatively high potential of causing of hypoglycemia. And so I think particularly in these patients, but I believe in every patient there should be some monitoring. So blood sugar random be checked in the afternoon around 3 o'clock or 4 o'clock in the afternoon, or whenever there are symptoms suggestive of hypoglycemia. Now, based on value, we can take certain actions. If sugar is more than 130 at 3 p.m., then no immediate action is needed because 130 is safe, and same dose may be continued in subsequent fasting. And if the sugar value is less than 100, blood sugar be monitored hourly from that time onward till the time of Aftari, and from the next day I suggest that the dosage should be reduced by 20%. So whatever medication, especially if patient is taking insulin, then there should be some reduction in medicine. If patient is taking oral medication, I think there should be some reduction in dosage of whatever patient takes in the morning. Maybe you can half it, because 100 is at the verge of hypoglycemia and it is only 3 p.m. We still have 3 to 4 hours, and then there is a possibility of hypoglycemia. So from next uh, day, I think you should reduce the dosage. And if somebody's sugar is less than 70, that patient has got technically hypoglycemia. So it is recommended that the patient should break his fast and he should consume food. And from next day onward, you must reduce insulin by 20% at least. Or if patient is taking oral medication, you should reduce it to half. Now, let me say one thing. There are people who have no symptoms of hypoglycemia at 70 or even at 60. Now, if this is patient choice to continue to fast, they may be allowed to do so, but then you will actually check his sugar, or you ask him to check his sugar hourly. So if it drops further, then I think it is best to break fast. Then patient can of course keep another fast in non-fasting month. So I think to compensate. So this is the recommendation about glucose monitoring. And this is concerning hypoglycemia. And the next slide is about hyperglycemia. Recommendation number 19. So if somebody's blood sugar random at 3 p.m. is 350 milligram or more, or between 200 milligram and 350 milligram with symptoms, maybe vague symptom, undue fatigue, severe lethargy, uh, restlessness, I think you must check ketones. This much of glucose may not give much of damage, but if there is ketones, then there could be a significant problem. If the ketone in the urine or if the serum ketone level is elevated or the ketones are present in the urine, patient must be asked to break fast, because then there is a risk of diabetic ketoacidosis progressing to a more serious level. Breakfast should be broken. No, sorry, this fast should be broken, and patient should be given intravenous insulin and IV saline, because we are dealing with potentially serious condition. Uh, and if the ketones are negative, sugar is high, 350, and the ketones are negative, then you can be assured that there is no immediate risk. Then patient can continue his fast, but from the next day onward, you should adjust the medication, titrate them upward so that next day patient does not develop that much of hyperglycemia. Now, if patient develops ketones, you will of course give him immediate treatment. Then you should also make a joint decision with patient whether or not patient should continue fasting, because uh, I think this patient would require maybe few days to come up with another better plan. So it would be perfectly understandable if patient is instructed not to fast for 2 days till his sugar is in a safe limit. So this was recommendation number 19. Now recommendation of 20 is about those people who should not fast, or who should at least consult their doctors and ask if it is safe for them to fast. As I said in the beginning, it is actually the patient's choice. Even if patient is at high risk of developing hypoglycemia in fasting and patient wants to fast, it is his choice. We must respect his choice, but we must do our part to make it safe for him if he wants, if he prefers to, if he opts to fast. Type 1 diabetes patient, because type 1 diabetes often need frequent insulin injection and frequent feeding. Pregnancy patient already have a stressful condition, and then fasting would be a little tricky. CKD 4 and 5, especially those patients who are on renal replacement therapy, dialysis, I think it will be risky for them to fast. Decompensated chronic liver disease, somebody with cirrhosis and ascites, portal hypertension, heart failure, New York Heart Association class 3 and 4, those patients who have dyspnea or orthopnea, and then any disease requiring frequent medication. Somebody is asthmatic, he has to take medication sometimes frequently. Somebody has epilepsy or whatever reason, if frequent medication is needed. Then any patient who is too unwell for whatever reason, or frankly uncontrolled diabetic patient, all these patients must consult their doctors. Number one, first to ask if it is safe or if it is not safe, and if they still opt to fast, then significant changes would be needed. I think these patients have to remain in constant contact with their doctors throughout Ramadan to have safe fasting experience. So these were 20 different recommendations made by Pakistan Society of Internal Medicine. Summary of my presentation is to fast or not to fast remains a patient's choice, and we must respect his choice. We just have to make their fasting safe. The primary aim of medication adjustment is to prevent hypoglycemia and severe hyperglycemia. Some degree of hyperglycemia after iftari and after sahri would have to be accepted to avoid hypoglycemia. Then pre-Ramadan evaluation is recommended for all, but is essential for some. And the list I showed and in recommendation number 20, those patients who are at a particularly high risk of developing hypoglycemia, they must see their doctors and have the proper adjustment in the medication, and they must remain in contact with their doctor throughout fasting month. But others should also see, I think, their doctors, unless they themselves are empowered with knowledge and they know the medication they are taking is safe. And the medicines with low potential of causing hypoglycemia are preferred. And I have given you the list. I can repeat it. Metformin, GLP-1 receptor agonists, DPP4 inhibitors, SGLT2 inhibitors, acarbose, thiazolidinediones. These are drugs which have low potential of causing hypoglycemia. Then basal insulins and modern sulphonylureas, slow release sulphonylureas, they have moderate risk, and glibenclamide and NPH based insulin have high potential of causing hypoglycemia. Glibenclamide and glibenclamide metformin combination should be avoided during Ramadan, and NPH and NPH based combination should be avoided or at least avoided at Sahari. And basal insulin, patients who are on basal insulin or basal insulin plus GLP-1 receptor agonist, they should have their sugar tested before the month of Ramadan. If it is more than 120, they may continue the same dosage. If it is less than 120, they are instructed to reduce their dosage, basal insulin dosage by 20%. Consider switching to insulin analog if affordability is not an issue. Those patients who are on NPH or NPH based pre-mixed insulin, or they are those patients who are taking human insulins or human insulin and NPH combos, you can, I think, consider switching them to analog based combos, because technically these drugs are safer, uh, but they're slightly expensive. But I think this extra cost, most patients would be able to afford to have a safe fasting experience. Individual adjustment will still be needed as every human is different, and patients should be empowered to make minor adjustments. Many times we make adjustments recommendation purely based on common sense, and many patients with diabetes, they have developed that skill. So I think they should be empowered to make some changes in their medication on day-to-day basis also, especially if they are on insulin. So this has been Professor Aziz-ur-Rehman, and these were the recommendations approved by Pakistan Society of Internal Medicine. And I am here from Medurstand. You can learn more on this channel where this lecture is available, and many other lectures about diabetes and all topics in internal medicine are available. I am looking forward to see you there. But these recommendations are also published in the current issue of Journal of Pakistan Society of Internal Medicine. You can have full access on this website, psimj.com. You will have a Word format documentation, a document giving all these recommendations.